Scalpel? Check. Hammer? Check. Vibes? Always sterile. Welcome to Scrub. Alrighty, guys. Welcome back to the Scrubbed podcast. We are still going and we are continuing our theme, what seems to be the presidential lineup here. Been hosting yet another phenomenal AAOS president. So, just as a reminder, my name is Dr. Stephen Bokshan. I'm the head of Cone Health Orthopedics, and this is our podcast alongside my right-hand man. I have Kinley, the wonderful Kinley Hatch, back today, back from her temporary vacation. Welcome, Kinley.
Thank you so much for having me back.
And today we are so honored to announce a phenomenal orthopedic surgeon, the choice of Dr. Paul Tornetta. So today he has selected Dr. Kevin Bozic, who is a phenomenal, some might say game-changing orthopedic surgeon in the world of musculoskeletal care. Currently, he is the chair of surgery at University of Texas in Austin. Although his past is quite significant, and has played a massive role in what we call value-based healthcare in this country, basically defining how orthopedic surgeons deliver care, musculoskeletal care, among many, many other accolades, including previous president of the American Academy of Orthopedic Surgeons. Dr. Bozic, welcome. Thank you for joining the show.
Thanks for having me.
So you are currently at UT Austin. And so my understanding is that you're currently are still the kind of the chair of surgery as a whole and perioperative services.
Yes, I'm the chair of surgery and perioperative care here at Dell Medical School, and I was employee number 5, and now we have over 2,000. And so I came here in 2015 to start actually the first medical school that was started on a Tier 1 research university campus in 50 years. And it's been quite the journey, and very exciting and humbling, and a lot of great leadership development opportunities, and really been a great phase of my career.
So what is that like to, be so early in on a process like that? I mean, walk us through a little bit of where you came from, what it was like to get the call to say, hey, we need you to build. We don't know what we want you to build, but we want you to build something. And what's that like in your head?
Yeah. So how far back should I go when you say walk us through your journey?
From the beginning of kind of the new position of that first 5.
Yeah. So I spent the first 12 years of my career at UCSF, which was a great institution and a great experience, and have a lot of fond memories and great people I met there. And it really is where I got my start, and both clinically and academically and in leadership. And I had looked at a number of different traditional academic chair positions because I knew I wanted to leadership to play a significant role in my career, and didn't really find anything that really excited me, that it felt very traditional, and the kind of places I was looking at were just interested in incremental change and making, the status quo a little bit better. And this opportunity came up, and the inaugural dean was a guy named Clay Johnston, who really decided that his tagline was rethink everything, and really wanted to rethink the way that we do medical education, that we deliver and pay for healthcare, that we do investigation and discovery, that our value proposition to the communities that we serve. And so it was just an opportunity to start from scratch and really implement some of the concepts that I'd been studying and writing about, and learning about my career, but really never had the chance to implement them in real life. Some of these principles of value-based healthcare, both on the delivery side and the payment side. So it was an opportunity to do that in a great city, a growing city where there lots of opportunity for growth. It's a very easy place to recruit. People want to live in Austin, and so I've been very fortunate to be able to build a great team since I've been here, with a very high retention rate. The scary part is when you come into a new venture like this. I got here, there were no buildings, no people, just a vision. And being chair of surgery, I can't realize we can't do everything on day one. So I had to prioritize where we're going to grow, where we're going to build, where we want to have the impact. And it's a bit of a leap of faith when you come into a I've been in big established institutions my whole career, Duke at UCSF and the Harvard system, Rush. And so this was something that, you take an opportunity like this and you really don't know what the outcome's going to be. Now, I think you hedged our bets a little because we're at the University of Texas, which is, I kind of describe it as like being a startup within Apple or something. We're at a big established, successful institution with a long history of success and very deep pockets. And so the chances of failure, if you want to call it that, are pretty low. But it's just what are we defining as success and over what period of time? No one can guarantee that for you. And so it's been a great learning experience for me, very humbling. It's not, I'm right now the only chair of surgery in the country who's an orthopedic surgeon. And so, I have to learn a lot about cardiac surgery, vascular surgery, general surgery, transplant surgery, neurosurgery, plastic surgery, urology, ENT. So, anesthesia is in my department, emergency medicine. So lots of different disciplines that I had to learn. And I'm never going to be an expert in those disciplines, but I also learned that, to be an effective leader, you have to be helpful to the people that you lead. And that's really independent of the discipline. In fact, my leadership coach said to me, "Do you think that, Jeff Bezos is an expert in all aspects of Amazon, or do you think there's people at Amazon that might know a little bit more about supply chain and other things than he does?" And probably, but, it doesn't mean he can't be a good leader.
Yeah, and hats off to you, honestly. I mean, it's so easy for us as docs to kind of become experts in our own lane, right? And, in a world of increasing subspecialization and really only operating on the, distal phalanx of the fourth finger, to be able to zoom out and then see what our compatriots in the healthcare field are doing. I mean, that's a tall task and it's something that really shouldn't be understated.
Yeah, I always describe it's very different from a traditional chair job because if I was chair of orthopedic surgery like Paul Tornetta, who's a great chair and a great leader, by the time you become a chair of orthopedic surgery, and you are now, you're pretty well known, you're an expert, and people look up to you and respect you for your expertise in that field. I'm walking in and I'm the chair of, cardiac surgeons and vascular surgeons and transplant surgeons and general surgeons, none of whom in that field know anything about me. And so, it's pretty humbling. You have to learn how to be an effective leader without having that credibility that you automatically have when you're a chair of a department in your own specialty.
I think it's a
Yeah.
testament to your leadership style that you're willing to jump in and learn all of those. It would be very easy to jump to say, I know orthopedics, it's fine. I'll just treat everyone like I do orthopedics. How do you compartmentalize learning all of these different specialties and how they function and the politics behind it?
Yeah, that's a great question. First of all, I realize I don't need to be a content expertise in these areas to be an effective leader. I need to learn a little bit enough to be dangerous and, understand what some of their challenges and pain points are. But that's the favorite part of my job is taking me out of my comfort zone. I mean, I want to be challenged as a leader and I wake up every day and I'm uncomfortable in my job at some point every single day. In my prior job when I was at UCSF, great institution. I was the chief of the arthroplasty service and vice chair of the department, but I, got to the point where I could do most of my job, with my brain turned off. I knew how to operate. I knew how to take care of patients. I knew how to teach. I knew how to do research. I knew how to get on a plane and go somewhere and be a visiting professor. And so, I get to the point where you're kind of like, I need something to challenge me. And that's the part of this job that I love the most is solving problems, helping people solve problems, not solving them for them, but helping them learn frameworks to solve problems, and learning, constantly learning new things and new ideas and new leadership frameworks that'll help me be successful and help my team be successful. And so that's a lot of people say, boy, that must be really hard being, out of your comfort zone. And that's the favorite part of my job.
Yeah. I definitely believe in the notion that if you're not uncomfortable, you're not learning. And that's definitely a testament to that.
Yes.
So leaders aren't born overnight. And it's probably not something that we're even born with, period. So, Dr. Bozic, can you talk a little bit about your upbringing? What are some of these formative experiences that prep the stage for who you are today.
Yeah, thanks for asking. So, I grew up in Eastern Pennsylvania in the Lehigh Valley, and both my parents were immigrants. My father's an immigrant from Yugoslavia, and my mother from Canada. And in a very blue collar town, the Allentown, Bethlehem area. My father worked for Bethlehem Steel. And so, really learned a lot about work ethic and the importance of perseverance and not giving up through that experience growing up in a blue collar town and through sports. Sports are the great equalizer and the great meritocracy. And so, you have to earn your position in sports. And, I played team sports growing up. And then I had the opportunity to go to Duke for undergrad. That was, really a life-changing experience for me being in the South and being, actually around a lot of rich people, which I had never been around my whole life. And so, learned how to function in that environment and had a great experience. Was an engineering major, but an biomedical engineering major with the idea that I wanted to be an orthopedic surgeon. I was one of those kids that knew I wanted to be an orthopedic surgeon before I wanted to be a doctor. I went to Duke thinking I was gonna be an orthopedic surgeon. And then this was kind of a theme in my career as I finished college and I said, I think there's more to learn before I go off to medical school. So I deferred medical school for a year. I worked as an engineer in Silicon Valley for a year, which was another great experience for me and learned new skills, new ways of thinking, and then went on but with the idea that I was going to go to med school. But while I was, working in engineering, I kept an open mind about, well, maybe I'll find something I like, more than pursuing my dream of being an orthopedic surgeon. But I ended up going to medical school at UCSF, had a great experience there. And mentorship is another theme throughout my career. I had some great mentors early on and to this day that have had a big influence on my career, and ended up at Harvard, the Harvard Combined Orthopedic Surgery program, which was really unique because it's unlike a lot of residency programs where you're sort of based around a single hospital. We had 4 core hospitals and then some outlying hospitals. So got to work in a lot of different environments with a lot of different people. That was another place where I worked with a lot of really famous people with big egos, and a lot of people would say, "Oh man, that must be tough working with all these, big egos." And I learned early on that, I don't really care, what these people, if they look down on me, if they're condescending. I have so much I can learn from these people that I'm not going to let that get in the way of my learning. I get to work with, the greats. And so I don't really care if they hurt my feelings or say things that are going to make me feel bad. I want to learn. And so that was another experience where I learned resiliency. And then when I was in my 4th year of medical school, excuse me, of residency, and everybody started applying to fellowships, and I said, I know a lot about orthopedic surgery, but not much about anything else. And I thought, it was around the time, it was late 90s, and people were starting to talk a lot about the frustrations of loss of autonomy of doctors and the business side of medicine and how, doctors were being marginalized. And I thought, well, I had a mentor, Jim Herndon, who had an MBA, and I asked him about that. And it was a time when people did not, that wasn't a thing to do, to get an MBA as a doctor. But I really looked up to him and the way he thought. And so I said, well, I'm going to apply to business school. So I applied to 2 schools, Stanford and Harvard. I got rejected by Stanford and I got into Harvard, and I went there. And then that was another life-changing experience for me, being completely out of my element. I was with all a bunch of successful business people, because when you go to business school, especially at a place like Harvard, you have to have some established track record in business to get in. And so I kind of put my way through that part of the application and, talked about leading teams as a resident and things like that, but not compared to the people that I was with. So I was and Harvard Business School is taught through the case-based method, so they don't sit down and teach you and lecture you on finance and accounting and, and leadership and other things. So you have to I was, like, doing cases during the day and then reading textbooks on business at night and leadership and other things. And then that's where I got to meet Michael Porter, who ended up coining the term, value in health or value-based healthcare. And so that was another defining moment in my career. But what I learned most in that experience was, the importance of really what I learned in business school was leadership, and some of the technical aspects of accounting and finance and other things were really secondary. It was really how to lead an organization, because the vast majority of people that go to Harvard Business School go on to lead big organizations. And so that that led me to and again, when I was in business school, just like when I was working as an engineer, I decided to look around and I said, well, I'm graduating from Harvard Business School. There's lots of opportunities. So I interviewed for venture capital, private equity, investment banking, consulting. And I didn't find anything I liked as much as being an orthopedic surgeon. But at the time, I really had to convince the fellowships that I wanted to be a doctor, because nobody believed me that I wanted to be a doctor because I went to business school. And I didn't do the, nighttime or weekend. Harvard doesn't have that. So I took 2 years out of clinical medicine to get an MBA after finishing residency. And so it was, I had an interesting experience because I got a grant from the OREF, a career development award. So I had my own funding to be a fellow. With the fellowships I applied for, they didn't need to fund me. I was like an extra fellow, and I wanted to do it off cycle because I graduated from business school in June, and I didn't want to go right into fellowship having not operated in 2 years. So I went back to Mass General and did a 6-month mini trauma fellowship with the people who I knew. And it was, in retrospect, really hard. I, I always say, oh, it's like riding a bike, but it's really not. If you have 2 years of not operating, you have to learn things again. And I did, and I'm glad I did that. But then I interviewed for fellowships, and I interviewed at 3 places. I interviewed at Harborview for trauma. I interviewed at HSS for sports medicine, and I interviewed at Rush for arthroplasty. And I wasn't picking. It's what I tell our residents. I was choosing a fellowship based on the mentor, and I wanted a good mentor. And Chip Rout at Harborview ended up being a great mentor and still is to this day. But the person I chose was Aaron Rosenberg at Rush, who just recently passed away a few months ago. But he was a mentor who changed my life and taught me more about life than he did about orthopedics, and actually introduced me to my wife, and had a a real just influence on the way I think. And then the last thing I'll say about that during the question you asked about leadership is, I've had an executive leadership coach since 2007, and I work with her anywhere from an hour to 3 hours a week. And even in the midst of my schedule and everything else, I always prioritize that, no matter where I am in the world and no matter where she is in the world. This week she was in Prague for our session, but it's something that I realize that, as you said, being a leader is not something that you're born with. It's something that you have to learn, and that we can all get better at. I think as surgeons, we often assume, well, that's just part of the job, being a leader. And we put all of our effort into learning other things. And, I spend as much time, I have homework every week, and I spend being a leader is hard work, and it takes continuous learning. And there are frameworks and things that you have to learn. There's a lot of evidence-based science in leadership, just like there is in medicine. You know and there are things that I learn, and frameworks that I use that actually help me every single day. And then the other thing is, I also learn, what got me here won't get me there, right? Got me to this position are not going to help me be successful in this position. So, or whatever I do next. So I think I've learned the importance of really making my leadership journey an intentional effort, and something that I invest a lot of time and effort into. So that was a
Yes.
long-winded answer to a simple question.
Well, I mean, it's obvious you're an extremely capable person, right? You've, gone to school for engineering, you've done orthopedics, you've done an MBA. I mean, you name it, you clearly have taken on the challenge. But the thing I thought was cool was that after all of that, you chose orthopedics. And so, what I want to know is, like, with your father doing what he did and you making the very cool statement, I always knew I wanted to be an orthopod. What is it about orthopedics? Is it something about working with your hands? Like, what is that draw of all the things that you could do? You replace the hip, you replace the knee, you help people.
Yeah, so, I come from a family of engineers, so going back, my father's father was an engineer, and he was basically the equivalent of the head of the FDA in Yugoslavia at the time before Yugoslavia broke up, and he actually got his PhD under Albert Einstein in Germany, and so we have handwritten letters at home from between my grandfather and
That's
Albert Einstein.
wonderful.
But then my father was an engineer. My brother was a computer science engineer. My brother actually was one of the first 100 employees of Oracle. So he went to Carnegie Mellon, and then ended up working at Oracle right when it started. But I really liked that. I really liked the applying engineering principles to solving problems. And then I had an experience probably like a lot of orthopedic surgeons at a young age where, I broke my wrist and met an orthopedic surgeon and I said, "Wow, this seems like a really cool, way to apply engineering, but to the human body." And so that's what I got interested in, and also just, I looked up to and respected this orthopedic surgeon who took care of me, and I thought, I really, wanna be somebody like this that can influence a lot of people's lives. And so that's how, and then all throughout my journey, every time I looked around and said, "Is there something else?" Whether it be in medical school, I actually my favorite rotation in medical school was psychiatry, and I think going forward, that's a big part of what we've tried to do here. Is I think we've always separated out mental and behavioral health from physical health and thought of them as separate disciplines, but they're really not. And so we have a behavioral health integrated into our musculoskeletal practice, not like a separate referral, but part of it. But, I still enjoy I think the thing I like most about our specialty is, we help people get better. We help them, we empower them to, we don't do it for them. We empower them to improve their function and quality of life. And there's a lot of things in medicine that either end in, death or morbidity, or the best you can hope for is to slow the progression. And we get to actually help people get better. And the relationships I've had, I'm sure like both of you, with my patients over the course of my career, and the that I've built, and the friendships and joy that you experience when you get to help somebody, there's really nothing else like it.
Yeah.
You
Profoundly
actually 100%. You actually touched on, you said, "What got you here won't get you there," which is the title of my favorite book by Marshall Goldsmith, who I read about. I read about every other year just to check where I'm at. How has your leadership or your leadership style or your practice style changed throughout the years as you've gone through all of these accolades and gotten these titles?
Yeah, dramatically. So I do a 360 leadership evaluation every 2 years with my coach. And when I first got here, the first time I did a 360 here, it was humbling. I thought I was this great leader, and what I learned was I had a lot to learn. And the most important thing was to be an active listener. I was doing a lot of talking and not a lot of listening. And the other thing is, and so that's something that's changed dramatically. But the other thing, and I always tell people this as you move up in leadership ranks, is the importance of relationships. So I would say 80% of my job now is relationships. And I'm an introvert, a strong introvert. And so I'm the kind of person that, like, if I get to eat lunch, I like to get my lunch, shut the door in my office, and do email and eat lunch. Like, the thought of sitting down and making small talk with somebody for lunch, like, I'd rather, stick needles in my eyes, right? And I'm in the South, and in the South, relationships, like, you don't do, business over email or text, or, you sit down across the table from somebody, and that's how you do business in the South. And so that was a painful lesson for me. But now I've learned that, my coach, I can hear in the back of my head, relationship first, relationship first. So whenever I'm tackling a difficult problem, I'm thinking about, this week I had 2 different times when I, took someone out to dinner and spent, several hours with them, and just getting to know them as a person, what drives them, understand, their family, what are what's going on in their life, and then that helps me, build that trust that I need to be successful. And it's the same for the people on my team. So I have, with the job I have, and then, I had this job, and I have 250 faculty and huge staff, and then at the same time, I was president of the American Academy of Orthopedic Surgeons, which is a 180-day-a-year job. And so I had to figure out, how to delegate and be effective. And that's another probably topic we can touch on, because that's probably the most important skill to be in a position like this, is time management, and how to figure out what you spend your time on and what you don't, and how to separate the not let, urgency define importance, but really focus on what is truly important and what are the things that only I can do to help my team. But one of those things is being there for my direct reports. So I have a rule with my executive assistant that I have 17 direct reports, and if any one of those people needs to get in touch with me, we do that before the sun goes down that day. So doesn't matter where I am in the world or what I'm doing. If somebody says, if Kinley says I need to talk to Kevin about something, we figure it out and we make it happen. It might be at 7 o'clock at night, but I'm not going to let the sun go down. And when I'm here, like when I was president of the AOS, I was traveling every week, but so I had to cut out a lot of things, but the thing I didn't cut out was my leadership coaching and my one-on-ones with my direct reports. So I would always have and prioritize those meetings. So I think relationship, and then, servant leadership. It took me a while you always hear when you step into a leadership role like you're in now, Stephen, that it's about the other people, but I still wanted to be a great orthopedic surgeon and the go-to person in my community. I still wanted to be president of the AEOS, and I wanted to be famous and all those things. And then I realized that those were not the things that brought me joy anymore. The things that brought me joy were watching the people around me become better leaders and becoming more effective and getting recognized. And those are like the things that truly in my soul that bring me joy and make me happy now. It's like bragging about my kids or something. So I really that part, as well as, I really, when people ask me what's my leadership style, I say I really believe that, to be an effective leader, you have to be a servant leader, and you have to define your success by the success of the people around you and put their needs ahead of your own.
Yeah. Yeah, truly. I mean, teach a man to fish versus give a man a fish. When you're meeting, I guess, a direct report, or I guess anyone for that matter, like what goes through your mind in terms of, as you're getting to know someone, like how are you assessing kind of what their leadership or what their leadership capacity is? Like, is this something by default you're going to spend hours and hours with each of your, direct reports? Is this something that you only kind of give to them when they need? Like, help us understand what it's like to be a leader that's not just passive, but an internally active, if that makes sense, leader, saying, who needs me the most right now? Because there's probably a lot of people that need you at any given time.
Yeah, so that comes back to the topic we were just talking about, like where do I spend my time? So I have this grid that I do with my coach, and I do it with all my direct reports, where you look at effort and impact, right? So there's 4 quadrants, and there's a lot of things that we do that are low effort and low impact. So you could say, well, it doesn't really have much of an impact, but it doesn't take much time, so I'll do that. That's the bucket that will crush you as a leader, because I have, like, my vice chair does a lot of stuff, and then, oh, I don't want to burden my team, so I'll just do it. Well, guess what? That's actually selfish, because now you're doing things that other people can do, and you're not doing the things that I need you to do. And then there's high effort, high impact, and then there's actually things that are relatively little effort that have an high impact, and that's relationships. It doesn't take a huge amount of investment to, try to build a relationship and focus on getting to know someone, but it has a huge impact. And then there's high effort, low impact, and those things are no brainers. You can just get rid of those. And so I do something with my whole executive team. There's 4 people on my executive team, including my executive assistant. Every 6 months, we do something called a calendar pruning, where we go through and look at, now we use AI, so it's great because we can see how much time I spent on everything, and I want the coaching and the one-on-ones and the development to be at the top. And if I find out I'm spending my time on a lot of operational things, I want the strategic things to be at the top because I'm the CEO. So I really want to be focused on strategy, not operations. And I find, the operational stuff creeping up on my time. Then we just, we cut that out. And what I do is every single thing on my schedule or every responsibility that I have or the department has, the first thing I say is there's someone on the team that can do this as well or better than me. And usually the answer is yes. And then I don't do any of those things. And some people will say, oh, well, that's really selfish. You're making everybody else do all your work. And I look at the opposite. I say, if I'm doing that stuff, that's selfish because my team needs me to be doing the strategy and thinking about the future and where we're going. And I'm doing stuff that somebody else could do. Like I don't ever look at my calendar. I'm actually don't even have editing rights on my Outlook calendar. Like the executive assistant does all that. Could I go in and move things around? Yeah. And if I ever try to do that, I inevitably screw something up. That's something that I didn't know about that she knew about that slot was being saved for or something. So, but that's an example of things like, could I try to manage my calendar? Probably. Would I ever be as good at it as Mickey? No. And would it be a good use of my time? No. So I think it's focusing on the areas where you think you can have the most impact. And so that gets to your question of, so what does that mean when I meet with my leaders and develop them? And it depends on what stage they are at their career. I just had a transition in the division chief in one of my divisions, and it's somebody that was a relatively new leader that had not a good surgeon, but didn't have a lot of experience in leadership. So that's somebody that I approach and say, okay, this person I'm going to need to treat differently because they don't have experience in these roles. They just have to understand like what's going to make them effective in this role versus somebody who's been, I have a leader on my team who was the president of the American Board of Urology, is the probably going to be the COO of our new hospital, a very experienced leader. That person needs different things from me than the person who's starting out in their leadership journey. And then the other thing is I'm a real stickler for agendas. Like every time I meet with my one-on-one, they have to give me an agenda ahead of time, and it can be their standing agenda. I want to talk about my faculty, some of the challenges, whatever. But if they show up in my, ante office with my assistant, they don't have an agenda, she'll just turn them away and say, we'll reschedule you next month. I don't want to walk in there going, gee, what are we going to talk about today? And yet I learned from my coach, I start every meeting just asking them how they're doing and trying to understand what's going on at home, what's going on with your family. We have very strong cultural norms in our department that we developed as a team. And by the way, I've been here 11 years and we have a 94% retention rate amongst our faculty. And the only ones that have left for, bigger jobs at bigger places. And so a lot of that is because we have strong cultural norms that we hold each other accountable to. And one of those is we are more than our work. And so I always say I'm the type of chair that's more likely to chase you out of the operating room at 7 o'clock and tell you to go home and see your family than I am to say, how many cases did you do this week or how many work RVUs or whatever. And so I think, making sure that the people that you work with and work for you know that you care about them as a person, and not just the productivity that they bring or the function or the skill that they have on your team, I think is probably the most important thing in terms of developing that trust and being able to build them as a leader. And that more senior leader I mentioned over time has gotten to the point where he'd be like, well, I don't know if we need to have this meeting because we see each other in, different contexts at the week. And then by the end of the meeting, he's always like, I'm really glad we had that meeting. Learned something and I picked something up from that.
Yeah, no question. I mean, it's so your leadership framework is amazing. Very clearly, you spend a lot of dedicated time thinking about this because, these things don't just come out of nowhere. But, I found your comment interesting about AI in terms of using AI to kind of synergize. So many of us, or so many people, I'd say, in general society, kind of use AI as a duplicate for their thoughts or their brain process. And that's what scares me the most. I think it's very cool that you've already built these frameworks that are successful and capable of developing leaders. And then instead of using AI to think for you, you use AI to think kind of with you. So has that changed your practice a lot having that?
It's since you say that though, because I'm worried about that for myself because I give a lot of I do a lot of public speaking, and, I used to spend hours and hours writing my remarks, and now I say, "Okay, I have an audience with, Stephen and Kinley, and, we're gonna be talking about value-based healthcare in this context, give me some talking points or whatever, rather than thinking about it myself." So I'm just as guilty of doing that, and I worry, like, I can't remember the last time I've had to sit down and, like, really think hard about what I'm gonna say. I mean, it's something as informal as at a faculty meeting, like, what are my opening remarks at a faculty meeting? And I don't know which, engine or bot you guys use, but I use ChatGPT, even though I've been told I should be using Claude. I was told Claude is better. It knows me now, so it knows me what, like, even the other day I was comparing, electric cars because I wanna switch cars, and and it said, "For an urban physician executive like you, this is what I recommend." And I was like, "Oh, yeah,
What did it recommend?
it's the Rivian R2." I've had a Tesla since 2017, and it's time to get a new car, and I wanna the Rivian looks cool, but the base Rivian is like a big block truck. It's too big and too clunky, so this R2 is like, it's not even out yet, but it's like their SUV versions.
It's scary how much it gets to know you for
Yeah,
sure.
yeah.
But thank you for your honesty on saying you also use it to think sometimes because it's very easy to slide this off as like, I'm a surgeon. I don't need AI to do this. But thank you for your honesty on that, that you don't have to think and you take away your thinking power on some things.
Yeah, and then but and the flip side of that is, if it's a meaningless thing like writing a promotion letter, which I get asked to do all the time, I don't even read like what it writes. I just put in the CV. I put in the CV. I put in the criteria for promotion. It spits out a letter. I send it to Mickey. She form. In fact, she even does some of it for me now. I don't even look at it. I'm like, oh, we got another promotion letter. Generate that and sign it for me. So the stuff that you don't want to put brain power into thinking about, it can do for you.
Well, at the end of the day, though, I mean, that's completely symmetric with the way that you lead, right? Which is if I have some task X that's better served by, it doesn't have to be person Y. Now it can be AI Y. That allows you to keep your brain where it needs to be, right? Which is strategic development and processes that are not just going to change the way that your health system works, but probably processes that are going to change the way that the country's health system works, which is awesome. So, do me a favor. I do want to chat a little bit about kind of value-based care. And a lot of this conversation might get a little bit heavy for some of the listeners who aren't necessarily in healthcare, but do me a favor. Are you able kind of talk a little bit about historical kind of fee for service orthopedics and how that's changing into what we call value-based care, which what I'll call is more of like a holistic model of delivering care, and what has it been like for you kind of going through that change and honestly being at the forefront of the change?
Yeah, thanks. And by the way, I don't have a hard stop at 9 if we have to go over a little, because I know this is an important part of the conversation. You guys might have a hard stop, which is fine. So it's funny you say that because it might get a little heavy and technical, because I give talks on this topic all over the world. And the first thing that I say in those talks, and I've learned this over time, is we have made the term and the topic value-based healthcare way too complicated, to the point where the average, even, healthcare executive doesn't understand it, let alone the average, person on the street. And I learned from this book by the author of Essentialism, but it wasn't that book. It was a subsequent book that he wrote, the term Sesame Street simple. And he says, don't go for, the message that makes you sound really sophisticated and important. Go for the message that anyone can, understand and repeat. And so now when I talk about value-based healthcare, I think about explaining it to my 15-year-old daughter so that everybody can understand and we're all on the same page. So the first thing for people to understand is it was developed by two health economists at Harvard Business School, and they're economists. It was a framework for competition based on value delivered to patients. So instead of us competing on rates or on volume or on reputation we're actually competing based on value delivered to patients, which is way most things work in a capitalist society, and where value is defined as health outcomes achieved per dollar spent to achieve those outcomes. So in other words, we're going to compete on how much health I can get you for the money you spend. And so that's really what the framework means. And the first and most important thing that I want your listeners to understand is if you don't improve health, then you didn't create value. I don't care how much money you saved. You can give me the most cost efficient, safe, and effective health care. And if it didn't improve my health, you gave me no value. You created no value. And so that means what? That means we actually have to measure health from the patient's perspective. And in our world, that's pain, functional status, quality of life. That's patient reported outcomes. And so the first basic principles, we actually have to measure health from the patient's perspective. And we have to understand if the things that we're doing improve health. And if they don't, we can forget about the cost, the safety, the quality, all that stuff. It's about health. It's not about quality, even though quality is important. It's not about safety, even though safety is important. And it's not about cost, even though cost is important. It's about improving health. And it just so happens that health is less expensive than disease. So if you help someone improve their health, then you're going to spend much less money on healthcare over time. And so I think that's probably the most important thing to understand about value-based healthcare is it's about competing in this healthcare universe on the value we deliver to patients, which is on how much we help them improve their health with the money they spend on healthcare.
Yeah, so as a kind of a simple framework for folks listening, right? So it sounds like health is your numerator and cost is your denominator. Super theoretically super simple, but then we talk about, well, how do you define health? Cost is somewhat a little bit easier, but health obviously is complicated. So historically in orthopedics, right, we're no different than any other trade, or medicine, we're no different than any other trade, right? Someone comes to you, historically it was, fee for service. I want a knee replacement, how much do I owe you? And that was very transactional. But as you noted, right, how many things are we missing there, right? How is the patient actually doing? Did the patient get readmitted for, any number of complications? Because as a surgeon, I didn't do my job prioritizing or getting them healthy for the surgery. So what's that like? Like what, you talked about how healthcare, or sorry, value-based care first started. Like how does anyone first begin to conceptualize, okay, we're not just going to charge X for this procedure. We're going to get a bucket of money, right, from someone. And how do we think about delivering optimal value-based care? Like where do you even begin thinking that? Where do you go? Because you can go so many different directions.
So I'll say two things about that fee for service versus, and then I'll get into what drives that. So there are two predominant healthcare payment models in the US are fee for service, which incentivizes time and intensity of services. So more services equals more revenue. And then capitation, which is less services equals more revenue. And so I think neither of those are aligned with value. What's aligned with value is episodic payments organized around conditions which do two things. It incentivizes you to focus on the outcome that matters to the patient, and it forces you to build teams, multidisciplinary teams of people that are responsible for managing those conditions. And so form follows function, right? The reason we need a different payment model is when you change the delivery model to focus on the outcome that matters to patients, the first thing you realize is, well, I need a whole different team of people to do this than an orthopedic surgery practice. And if I want to be successful, I have to be paid differently than fee for service. Otherwise, this model won't be successful. So it starts with, what do we do? What are we in the business of doing? We're in the business of helping people improve their musculoskeletal health. Well, there's a lot of things that go into that. And I always say, if health is your goal, which I think it is for anyone in healthcare, then healthcare is part of how you improve health. But it's not the only way you improve health, and it's probably not even the most important way you improve health, right? So if you want a team of people that are in charge of or responsible for helping people improve their musculoskeletal health, you need people that are trained in behavioral health. You need people that can help people understand how their mind-body connection works in the biopsychosocial model of healthcare. You need people that can help people lose weight and exercise. You need, people that can help people change their mindset. So we have a team of people that includes, and you don't need a lot of orthopedic surgeons, by the way, to help people improve their musculoskeletal health. You think about the universe of patients that have musculoskeletal problems, and it's big. pretty much everyone you've ever met, and you need a lot of people, and maybe, maybe 10% of those people ever need to see an orthopedic surgeon. And then of that, maybe 10% of those people might have surgery, right? So it's like 1% of the universe of patients but yeah, what do? We have a system that's set up where orthopedic surgeons are managing that. So what does that do? It does two things. It drives up the cost of healthcare because we got orthopedic surgeons who really want to help, and the thing they know how to do best is operate. And you have orthopedic surgeons who are seeing patients that are morbidly obese with chronic depression who they can't help, and that burns them out because it causes moral injury, because I'm sitting across from you going, I can't do anything for you. And the patient walks out saying that was useless. That was a waste of my time. And so it makes them feel bad. It makes me feel bad. It leads to burnout, turnover. So we have a team where the front lines are advanced practice providers that are trained in musculoskeletal health. This isn't rocket science. You can train just about anyone to manage musculoskeletal health in about 6 months. That's how long it takes us. And then we have physical therapists, we have podiatrists, chiropractors, social workers who are trained in cognitive behavioral therapy, we have dietitians, health coaches, and then we have some orthopedic surgeons. And so if you have a model that's set up that way, what you want is, so we have something called a condition-based bundle payment where we're paid prospectively upfront for the management of a chronic musculoskeletal condition, whether it's arthritis, back pain, joint pain, whatever. And we are paid then for a year's worth of services. And then everything we do to that patient during that year is already covered, and we're held accountable to the outcome that matters to the patient reported outcome. So what does that do? It incentivizes us to build a team of people that can manage and optimize their musculoskeletal health. And you don't want a bunch of expensive orthopedic surgeons sitting around, looking for people to operate on, because you're going to lose money in that model. And if you're in fee for service, then yes, you want to have orthopedic surgeons that are operating. But if you're managing musculoskeletal health, which is delivering the most value to patients, you need a multidisciplinary team, and that forces you to build that team. And then you learn from what you do. Oh, that didn't work. I'm going to try something else. And I don't have to go to the insurance company and ask for prior authorization to do whatever it is I want. I've already been paid up front. So it leads to better outcomes for patients, lower cost of healthcare, and most importantly, less moral injury and more joy in practice, because everyone's practicing at the top of their license, doing the things that they love the most.
That's awesome. I mean, that is so refreshing to hear someone think about orthopedics like that because honestly, we all have the same pain points, right? Which it's mind blowing to me how much access, patients have to an orthopedic surgeon. And, it's not a bad thing. I love people. I love talking to patients. I love getting to know about them. But, at the end of the day, the reality is if I'm being a good surgeon, the percentage of people who come across my door that I'm going to operate on is a relatively low number.
Yeah.
And that's going to result on a lot of us not practicing at the top of our license. Was behavioral health, so you mentioned it a couple of times, was that kind of one of the biggest game changers? Or, what would you say was probably the one or two biggest kind of, game changers when it comes to changing the way you provide value-based care?
Yeah, so I think that came from we screen every patient. We have behavioral health and physical and emotional health, patient report outcome measures that we get on every single patient before they walk in the door, whether they do it before the visit or before their room. Nobody gets roomed without having. So we screen for anxiety and depression. We use PHQ-29 and GAD-27 on every single patient. And about more than 50% of patients who walk through the door have either mild to moderate, in some cases severe, anxiety and depression that's maybe related to their musculoskeletal condition. And I think most of us say, well, gee, I don't need to ask them, their pain and function, I don't need a survey to tell me that. I just ask them. Well, guess what? I guarantee you don't know what's going on in their head and how they're approaching whatever it is that they're experiencing. And so when we realize that there are that many people that have behavioral health issues that specifically are impacting their musculoskeletal complaint, we're not trying to cure depression, or we're just trying to understand that the treatments that you offer people with severe depression for the exact same musculoskeletal complaint are different. You're not going to treat a patient with severe depression and anxiety with surgery, no matter how bad whatever their musculoskeletal issue is, right? Because they're not going to do well. You need to help them focus on that, not to cure their depression, though that's for other professionals, but to help them get the best musculoskeletal health and outcome that they can. So when we realized how prevalent it was, we said, "Oh well, we need people in our practice that know how to do that because not many of us." And it was the same thing for weight management. There's so many patients that come in to see us that have issues with their weight. None of us, you and I, never trained on anything about metabolism or nutrition or any of that. That wasn't part of our training. Having an orthopedic surgeon responsible for managing depression and obesity, it's a model for burnout and dissatisfaction from the patient and the clinician. So that's when we realized we needed a multidisciplinary team.
I think that's such
Yeah.
an important expectation to place on both you as a provider and as your patients. And I just think, wow, I'm just blown away that you guys have done this and focused really hard on it.
Pods. I mean, we're in a kind of an interesting field, right? Because, no one's gonna, or very few patients are gonna go, you know what, my blood pressure feels high today. Like, I'm gonna go to the blood pressure walk in, urgent walk in. But people are gonna say, hey, my knee hurts, and I don't really have a primary care doctor. I don't really feel like I need one. I'm kind of healthy, but my knee hurts and I really don't want to deal with that anymore. So I'm gonna go see an orthopedic surgeon. I think for us, like one of the best strengths we have is we're a huge area of just input into the medical field. So like for you guys having these questionnaires, like sure, you're not going to be managing like complex depression or something, and you don't want an orthopedic doctor doing that. But just knowing that it exists and being able to offer someone some help, I mean, those patients must be tremendously grateful.
Well, and the other thing you said is it's really odd and unique the way that musculoskeletal disease is managed in our health system. And you said the word orthopedic surgeon, right? So I always say, if I wake up with a headache, I hope you don't send me to a neurosurgeon as my first stop, right? But if my knee or my shoulder hurts, you go to an orthopedic surgeon. So that makes no sense to me. And I don't want to see those patients. You don't want to see them, and I can't help them. Like there are other people that can help them a lot better than us. Now, do we as orthopedic surgeons want to be leaders in managing musculoskeletal health? Yeah, that's the mission of the AEOS, is to be the trusted leaders in advancing musculoskeletal health. But that doesn't mean we need to be doing all of it. It's back to the leadership conversation we had. We need to lead teams of people that are doing that, and we need to be in the background helping, coach them and be there for our expertise. But being the front lines of seeing every patient with a musculoskeletal complaint, that's a recipe for burnout.
Yeah. Yeah, I think, one good example of this that I like to use because, my wife herself was on steroids for about a decade before she turned 20. She actually broke her hip from a fragility fracture, femoral neck fracture on stage during opera because no one knew that steroids cause osteoporosis. But I love to use osteoporosis as an example because as an orthopedic surgeon, right, you get a hip fracture, you go in, you do your nail procedure or whatever, and then that's where it ends, right? We take the staples out, you say, hey, I hope you're doing well. And lo and behold, no one's thinking about how do we prevent that fracture on the other side, right? So what caused that? How do we prevent it? And as orthopedic surgeons, we're busy, right? Someone like you's got an amazing name in the community. I mean, people want you to do their hip and knee replacement left and right. And in a perfect world, that's what you're thinking about. You're putting in the perfect hip and knee replacement. But it doesn't change the fact that at a minimum, as leaders, we do need to have the teams of bone health folks that can mitigate all of the cost because these patients will come across our desks.
Yeah, it goes back to what we talked about is what's the goal? The goal is to improve musculoskeletal health. So if you use that as the goal, then that helps you decide who needs to be on the team and how you want to get paid.
So, you've had an amazing experience with value-based care today. And it sounds like you truly are very far ahead of the game for what most healthcare systems are doing. How has this changed medicine? Has it changed medicine for the better? Do you think this is going to be obviously we always improve as a profession, but do you think this will become the sole and primary payment kind of methodology? What have you learned from the process? Are there things we should be thinking, changing?
Yeah, I mean, the short answer is early in my career, I was very idealistic and thought, everyone was going to practice the way we do. And I realized that the things that we do here, I had a big advantage because we came in and set this up from scratch. I didn't have to re-engineer an existing system. We do, by the way, for you and all your listeners, we do what we call a value-based healthcare immersion program where we bring people down to Austin for basically 24 hours, like a noon on a Thursday to noon on a Friday, and embed them in our model and teach them. And now we've kind of metastasized to different parts of the country where people are doing these things. But I also know there's a place for fee for service, and there's a place for, very the other thing that we learned with these quote unquote value-based payments was when we did them around the 90 days of a procedure, we made the procedures very effective and cost effective and efficient, but we didn't ask the question, was that the procedure the right thing to do in the first place, right? So that's why you have to move upstream from procedure-based bundles. But I do think, I mean, obviously what we're doing now isn't working. The healthcare system's going broke. There isn't when people say to me, oh, well, fee for, or, value-based healthcare, that's a race to the bottom. They're constantly moving the target price, blah, blah, blah. I say, well, what do you think fee for service is? How are those conversations going when you go into those contracting negotiations every year? What's Medicare doing? Nobody's looking to increase your fee for service payments. And it's not the right thing. It's not aligned with what our patients want or need. And so I do think organically we're going to see more of a transition to different types of payment models. But I want people to keep in mind when they do that, you can say value-based healthcare. It's not a payment model. It's a different mindset. It's a different way of approaching what we do and what our responsibilities are. So when I talk to different audiences, I don't care if you're an intern or you're, a chair of a department, an athletic trainer, a physical therapist, a medical student. If you change your mindset to think about what's the goal here? What am I trying to do? What am I trying to help this person with? And what are the skill sets and people that I need to accomplish that? That's value-based healthcare, at its basic level. It doesn't Value-based healthcare works really well in a fee-for-service environment, focusing on getting what's best, getting the best outcome you can for the patient with the resources they have available. You can do that in any model. You can do that in the Ukraine, you can do that in fee-for-service, you can do that, it's just a mindset and how you approach your job and what we're trying to accomplish.
Yeah, team sports, ultimately you have the rules of the game, you know what you're trying to achieve, and then you build a team, right? And that team is directly related to what you're trying to accomplish. And that's clearly what you've done. So what one question I have about, value-based care is it kind of lends itself well to I think the discussion of direct to employer healthcare versus working with traditional kind of insurance companies. So can you talk a little bit about kind of what like direct to employer healthcare looks like and how kind of important that is for you?
Yeah, and I just actually sent a LinkedIn post on this very topic yesterday. So, because there was a Becker's article on, so first of all, you go back to like what's driving that. So employers, most large employers in your community mine are self-insured, right? So they use an insurance company, but what patients don't understand, that insurance company is not taking any risk. They're a third-party administrator. They are processing claims. So the first question you ask is, and I ask because I work with a lot of large employer coalitions, why do you use insurance companies? Because they can do a couple things. They can do contracting for us, so they can go out and get us the best rates, and they can process claims and they can give us data. Now, you could argue that data is claims data and might not be the best data, but they give us data. Most healthcare practices and healthcare organizations, their data sucks. They don't have any data to share with those employers. So, when I talk to employers, they say, I don't have a problem, paying more for healthcare, but I don't know if that's actually helping my employees get healthier. Like every year, healthcare is a larger and larger percentage of my operating budget, and I don't see my employees being healthier or happier. So like, I don't know what I'm getting. So the number one thing that we have to do is actually have data that we can share. So there's a huge opportunity if you actually measure the things that matter and you can share that with employers and you can do it at scale, then there's a huge opportunity to disintermediate the payers who really, I would argue, aren't adding value. They're processing claims, sharing data and doing contracting. There's some value to that, but they're not adding value in terms of helping people get healthier or reducing the cost of healthcare. And so the challenges with doing direct employer contracting are, it's scale, right? So even in our market, our biggest direct to employer contract is with our county health district, which has a captured population of medically indigent patients that have very little choice. So we can apply this model because they don't have 5 other places to shop around to. if you're going to go to, let's say, Dell Technologies, which is in our market, they, if you look at, they may have 100,000 employees in Austin, but they have employees all over the world. And then, you're going to offer them a differentiated service, and patients don't like to be told this is where I have to go, right? They like to have options. So then you have to realize that if you're going to change the payment model, you also have to change the benefit design. So you have to say to the patient, okay, yeah, you have choice, but if you go here, you have no copay, and you get more access. And then if you do that, and you have 100,000, patients who are in the workforce, the vast majority of them are pretty healthy, and they're not going to access the healthcare system, right? So now you're whittling it down to what are the actual number of patients that are going to access the healthcare system. And so when you hear, Walmart say we're going to do a program for, we're going to partner with Cleveland Clinic for our cabbages and our joint replacements, well, how many patients in a year are actually going to use that service? So there's a scale problem with it, but it's driving the right behavior regardless of how many patients it impacts, because the employer is saying, I want the biggest bang for my buck. I want value. I want to know what you're doing for my employees and what I'm paying for it. And so the direct to employer model has forced the conversation around value. And now we have to figure out the logistics of scale and contracting and other things like
Yeah. I mean, I think that you're exactly right in the sense of it's getting so much harder for business, even large businesses, to stay healthy, keep a healthy bottom line. And, at the end of the day, the healthcare system needs to be responsible for our cost, right? I mean, it's just blows my mind how out of control costs for even basic surgeries. Having a patient on the other day has told me they got a $30,000 bill for an ankle fracture surgery. It's gotten to the point where it's almost scarily untenable. Particularly as we continue to have kind of an inverted population with a booming baby boomer population that increasingly needs our services, and honestly not a lot of providers, not a lot of docs. So it's been very refreshing to hear how you've deepened your bench, broadened your bench. I mean, this is an amazing change of healthcare. Is this something that you got from the MBA? Is this something that you think about at night? Like you can think about so many different things clearly. Like what drove this for you?
Well, I was fortunate that when I went to Harvard Business School, I happened to step into a classroom, and my professor for competition and strategy was Michael Porter, who's kind of the godfather of competition and strategy. He's an economist, not a health economist. And then he got interested in health, and he wrote this book called Redefining Healthcare with Elizabeth Teisberg. And that what was where the framework for value-based healthcare was sort of launched. And so thought long and hard about these principles, and then I had the opportunity to come to Austin and actually implement it, right? So I got to build the team, and then I got to go to the payers or the employers and say, this is how we want to get paid for this. And so it was a really unique opportunity. And the biggest learning I've had from all this is, yes, it produces great outcomes for patients, and it lowers the cost of healthcare, but it improves joy in practice and retention. So our retention for our practice, which opened in 2017, this musculoskeletal practice is, over 90%. And that's through the great resignation and the pandemic and everything else, where everybody was moving jobs. And it's because everybody loves what they're doing, and their incentives are in line with their patient. Nobody's breathing down their neck saying, how many RVUs did you do this week? And showing them metrics about their, cost per patient and all that sort of stuff. They're actually letting them they're freeing them up to do the things that they love doing and that they're best at. And that keeps people coming back every day.
That's awesome. So one question I always ask everyone, and you'll be no different, is if you could look back at your career to this point today, or your body of work, is there anything that you would have changed, or is there anything that you would have told, a young version of yourself, hey, watch out for this, or be aware of this?
So many things. I think maybe the first one is, don't take yourself too seriously. I learned that, I started out in my career, and I sort of, you know, I knew I was interested in leadership. So I put myself in position to have leadership roles locally and nationally. And I started to drink my own Kool-Aid. And then I realized that we're all replaceable, right? If I wasn't sitting here having this conversation with you this morning, you'd have somebody else in this square in the middle here. and it would be just fine, and the world would go on, and you'd have a good podcast, and people would listen to it. So I think what I've learned is the only people that we're replaceable to are our loved ones, and so everybody else, if I wasn't doing this value-based healthcare stuff, or I wasn't the chair of my department, or president of the AEOS, somebody else would do it, and they'd probably do a pretty good job. But if I wasn't, a good father and a good husband, and there for my family, nobody else can do that. Nobody can replace me at that. So it took me a long time to realize that was, and a lot of missed, dance recitals and major family events for me to realize I got my priorities wrong. And now I don't. I don't miss birthdays. I don't miss, major life events. And I realized that, that's the most important thing in my life. Is, again, it goes back to the principle, what are the things that only I can uniquely do? There are a lot of other people that could do this podcast, and there are other people that can run my department, but I'm the only person that can be there for my wife and my daughters. And so that's probably, one. And then, the other is, we talked about the importance of relationships. And then the last thing on this topic of value-based healthcare is, I didn't really think about scale when we started. I thought about, okay, we're going to develop a new mousetrap, and then we'll figure out how to scale it. And I wish I would have thought about scale on day one and built it in a way that was more generalizable. So now we've sort of had to break it down and say, okay, well, you guys might not be able to do everything that we're doing, but maybe you can take figuring out how to integrate patient-reported outcome measures into your clinical decision making and use AI to do that, which is something that we do. Or you might be able to take adding a behavioral health professional to your practice or whatever. You can't do everything, but I think, I would have thought more about scale at the outset.
That's awesome. Yeah. And Kinley, I don't know how you feel about it, but we've now hosted, I think, 3 or 4 AOS presidents, and the amount of humility that we continue to see from all of the foremost orthopedic surgeons in this country is truly mind blowing. And I think it just goes to show you that in order to lead, you actually have to serve.
Absolutely. I was thinking the exact same thing, to be honest.
All right, so the moment of truth, Dr. Bozic, I could talk your head off all day about value-based care. I mean, it is such a massive topic. It's a topic that's not going away, but nevertheless, I think we've dipped our toes into it and given enough for our listeners to go off and learn. But without further questioning, the biggest question, which is, who do you think should be the next person that we invite on the podcast?
Yeah, well, I'm glad you and Paul told me that ahead of time, because I've got to put a lot of thought of it, and I'll break the mold of AUS presence, but I think someone who's going to be a future AUS president.